My passion for appropriate management of VPI is well known. My mission today to share that passion and to suggest some solutions. Most people think of VPI as an inadequate movement of the palate, resulting in poor occlusion of the nose from the mouth and resulting airflow where there shouldn't be. The occlusion of the nasopharyngeal airway is much more complex, involving the posterior and lateral walls of the pharynx in a sphincter movement and good occlusion. Even a minor defect can cause severe speech problems. This is an occult submucous cleft with no evidence in the mouth and shows a defect in the muscle sphincter, which results in poor occlusion. The causes of VPI are numerous. They can be structural, neurological, syndromic, or don't know in origin. The most common structural cause is cleft lip and palate. Such abnormalities are a feature also of many syndromes. The most common structural cause is cleft lip and palate. The absence of palate structure and therefore appropriate sensory feedback for articulation patterns before surgery can significantly affect praxis of speech after surgery and result in articulation problems even when the structure is normal. Syndromes can result in structural, neurological or cognitive difficulties affecting speech. This oral view shows asymmetric lift of the palate, a bifid uvula, and huge tonsils. To diagnose, you need to listen to the resonance, weak nasalized consonants, and all the other things on the list, a matter of looking for the significant symptoms. And looking beyond speech and resonance patterns to other clues can be helpful. All the above are important alerts to possible VPI. Any suspicions of VPI should lead to getting specialist advice if necessary. Regional teams offer SALT diagnostic equipment and medical specialist multidisciplinary team input. The specialist SALT input helps to interpret the patterns of speech to aid diagnosis. Oral speech problems indicate therapy, orthodontic treatment is needed. VPI-related problems suggest the need for surgery. Objective assessments, including endoscopy, videofluoroscopy, and airflow measurements, which give information about the nature of the VPI, are only available in such centres. The most skilled surgery, informed by a multidisciplinary team, is only available at these regional centres where surgeons learn together the optimum skills to produce best structure for speech. Treatment is designed to reduce the defect either with a flap of muscle or reducing the size of the sphincter. If surgery is contraindicated for any reason, various orthodontic plates can be used to the same end, that is, to reduce the size and function of the defect. And the management can be therapy before or after prosthesis, and the surgery is either a palatal re-repair to improve the function of the palate, fistula repair, or a flap, as we've just shown. And the diagnosis I got for this man was CVA causing dysphagia and dysarthria. And being a simple soul, I went to the ward and I looked in his mouth, and there was a complete unoperated cleft of the palate, which was the cause of his dysphagia and speech problems. A quick medical re-diagnosis resulted in him being able to go home 2 days later, back to his own environment where he managed fine. And the same can be done for people of any age with the right diagnosis. So the specialist means you and your expert ear and diagnostic skills. Think airflow, resonance, speech, and every speech therapist has this ear, and with that then the right treatment can be given to the right children and the right adults without years of therapy that don't have any effect. Thank you.